Good afternoon, wherever you may be. Good evening. It's a pleasure to be with you to share some time for the next few minutes talking about a a topic that on its surface perhaps seems somewhat straightforward, but which I think is incredibly complex and something I've been involved in for many years, including the development of many of the drugs that we'll talk about today. And in speaking about glaucoma medical therapy from a global perspective, I think it's challenging at best to talk about what goes on in every part of the world and every drug that's available. But I think there are some global principles that pertain to medical therapy that I'd like to discuss. Here are my disclosures. I do consult and work with a number of our industry partners in scientific advisory board capacities. So as with everything, things evolve with time. We live in an ever-changing world. It's often said that the only constant is change, and certainly we've seen that in the world of glaucoma medical therapy. I'd like to do a little stroll through time, if we may. We've had a long history in the development of our various classes of drugs. I'd like to walk through this in a bit more detail. And in particular, we'll talk a little bit about mechanism of action of some of these drugs in a few minutes and how that may be important and something we maybe don't think about enough. If we go back in time, it was the late 1800s when Eserin, a cholinergic agonist, was first introduced, derived from the West African calabar bean. And what was noticed with oral use of these beans was that it caused meiosis, and therefore it was found to be particularly useful in what was then iridectomy that was being done to break angle closure. Not long afterwards, pilocarpine, a direct-acting drug, was introduced, and then we had our first indirect acting drug many years later. It took over 60 to almost 70 years before we had an indirect acting cholinergic drug, followed about a decade later by phospholene iodide, which many of you shall know or may be familiar with. The miotics, pilocarpine in particular, was fraught with a lot of problems. You had to dose it 4 times a day. There were a lot of side effects. So there were a lot of efforts to try to develop different ways of delivering the drug through gel and extended release formulations to reduce side effects and dosing, but many of those really didn't persist and aren't available today. It wasn't until the 1950s that we had a carbonic anhydrase inhibitor developed, acetazolamide. Throughout this time, there were also several osmotic agents that were being used for short-term pressure lowering over many decades. In the 1940s, we had adrenergic antagonists that were noted to reduce intraocular pressures. Intravenous dibenamine was one of those, but but these drugs were limited by severe adverse reactions, such as severe orthostatic hypotension. Then we had the introduction of adrenergic agonists, just the opposite, and that was epinephrine. And it led to some topical and systemic side effects, but was found to be also useful in lowering intraocular pressure. It wasn't until the late 70s that we finally had another class of medications, the beta blockers, timolol, introduced. Timolol is a beta adrenergic antagonist. So again, we're using both adrenergic antagonists and agonists to lower pressure, which highlights, I think, some of the complexities of the physiology of the eye, that we can work on both sides of that equation for the desired effect of lowering pressure. were some side effects, of course, noted with these this class of drugs that was eventually um, overcome, and timolol was introduced. We then had an alpha adrenergic agonist, aproclonidine, developed, and then a more selective alpha-2 adrenergic agonist, brimonidine, in 1996. So a lot of development in drug pharmacology during this time. And we continued then to evolve with different formulations and molecules of adrenergic drugs, dipivefrin. We had the introduction of topical carbonic anhydrase inhibitors, dorzolamide, brinzolamide. And then finally, in 1996, we got a new class of medications, and that's the prostaglandins with the introduction of latanoprost. This opened up a whole new era. And 5 years later, we had other prostaglandin analogs, bimatoprost and travoprost, also introduced that proved to be very effective and which quickly became the first line gold standard drugs for treatment of glaucoma. Others continued to be developed in the family of prostaglandins with tafluprost, latanoprostene bunoid, latanoprost emulsion, bimatoprost, and most recently, finally, after another 21 years, we have another new class of glaucoma medications, the Rho kinase inhibitors, with the introduction of notarsadil. We've also had the evolution of a number of fixed combination drugs. In the US, these are the common ones used: dorzolamide timolol, brimonidine timolol, brinzolamide brimonidine, and notarsadil latanoprost, all combining drugs of different classes to try to enhance efficacy and enhance patient compliance. There's also a number of other, and I looked at some of the global literature, and there are fixed combinations available globally that have 2, 3, or even 4 medications in a single bottle. But I think it's important to keep in mind that fixed combinations are really compromises in many ways. We can't extrapolate how a drug necessarily does by itself in combination with another drug separately to what they would do when they're put together in the same bottle. Drug formulations are rather complex. To get the optimal penetration of the drug and the optimal efficacy, the formulation has to be of a specific nature. The pH has to be of a specific nature for that particular molecule. And when you mix another molecule in there, its sweet spot, if you will, for penetration and efficacy may be slightly different. So these formulations try to match those up as best they can, but they're often not ideal. But from a patient use perspective and for making it simpler for patients, they certainly make sense. But we have to realize that they're not the panacea for many patients that we would hope for them to be. And many of these fixed combinations, for example, in the US, with some drugs that may be approved in other parts of the world, I'll give you an example of the prostaglandin timolol fixed combination drugs, which were never approved in the US because they didn't quite meet the bar for efficacy that our FDA sought. So, but used separately, they can be very effective. So I think we have to realize that while there are some definite benefits to the fixed combination products for patients, we may be sacrificing something at the same time. Just to go through the classes a little bit and talk about mechanism of action. In the cholinergic class, we have really 2 ways of approaching it. The cholinergic drugs, or the parasympathomimetics, they're often called, they work by increasing the effect of acetylcholine at the receptor junction, the postsynaptic junction, as is shown up in that little cartoon on the upper left of the slide. What a direct acting drug does is it acts like acetylcholine and can bind to the receptor and activate it. That's a direct acting cholinergic or parasympathomimetic drug. An indirect acting drug enhances the effect of acetylcholine at the receptor by blocking the breakdown of acetylcholine, so that the acetylcholine that is released hangs around longer and therefore has more effect. In the end, they both work by enhancing acetylcholine effect at the postsynaptic junction. Our beta blockers, although they've been around since the late 1970s for glaucoma, the mechanism by which they work is still a bit of a mystery, at least to me. They work through cyclic AMP, it appears, and have an effect on the ciliary epithelium and therefore aqueous production. But I think there's still work to be done to understand how these drugs reduce aqueous production. The carbonic anhydrase inhibitors, carbonic anhydrase is an enzyme that catalyzes this reaction of reversible hydration of carbon dioxide. And that's used in the ciliary body to cause fluid flow and production of aqueous. So as is shown on the bottom on the left, that's the normal physiologic process that's happening in the non-pigmented epithelium that's leading to fluid flow into the anterior chamber as the aqueous humor. And if you block that reaction by a carbonic anhydrase inhibition, you block that process of fluid flow and movement of water molecules into the aqueous. By the way, in order to do this, the carbonic anhydrase inhibitors have to inhibit carbonic anhydrase activity in the eye by approximately 99.9%. So it almost completely blocks carbonic anhydrase activity, nearly 100%, with both the topical and the oral agents similarly. The only reason why the oral agents at times seem to work a little better than the topical agents is because on top of the carbonic anhydrase inhibition with a systemic drug like acetazolamide, you also get a metabolic acidosis because of the systemic effects, which is a diuretic effect, which also has an effect on the eye. Our alpha-2 adrenergic agonists, most commonly represented by brimonidine, they have complex effects on both inflow and outflow. And it's as I said, it's alpha-2 adrenergic. The alpha-1 effects, alpha-1 adrenergic agonist effects are things that probably aren't really beneficial in glaucoma therapy. It's things such as vasoconstriction and pupillary dilation. Alpha-2 effects are where we get IOP reduction. You actually get a little pupillary miosis. So the pupil constricts a little bit with these drugs, which is sometimes used for that purpose in certain circumstances. There may also be a potential for neuroprotective effects because of alpha-2 that have been postulated. And then the prostaglandins, there's a whole host of prostaglandins, as I mentioned now, and this list will probably continue to expand. They have a very complex mechanism of action through remodeling of the extracellular matrix in tissue through matrix metalloproteinase activity. TNF alpha is tumor necrosis factor alpha. And it remodels what goes on within the trabecular meshwork and the uveoscleral outflow system. What's frequently overlooked with the prostaglandins is that it's often said that they are uveoscleral outflow drugs, which they do have an effect on the uveoscleral outflow system. But the uveoscleral system on average, is probably 20% of the outflow. The majority of the outflow in the eye is through the trabecular meshwork. So what I often like to point out is even if the drug is having the majority of its effect on the uveal scleral outflow, it's having it on the smaller percentage of total outflow. So in my little attempt at math here, so if 80% of the outflow is through the trabecular meshwork and the prostaglandin has only 20% of its effect there, that gives you a net of 16. This is just very conceptual. And then it's just the opposite for the uveal scleral outflow, which accounts for 20% of the outflow. And if the drug has the majority of its effect there, 80%, it's still 16. So the point that the number 16 isn't important. What's important is that these drugs, on average, probably have about an equal impact on outflow, trabecular and uveal scleral, even though the majority of the effect is on the uveal scleral outflow pathway through the remodeling of the extracellular matrix in the ciliary body. And then most recently, we had these Rho kinase inhibitors, this newest class of drugs, which have also very complex mechanisms of action that works on actin fibers, and it's probably best illustrated in the slide on the right, where you see on top the normal composition of the trabecular meshwork there in the dark blue with the TM and the bar across it. That's the normal trabecular meshwork. Above that, where it says SC, that's Schlemm's canal. After Rho kinase treatment, the trabecular meshwork looks as it does on the bottom slide there, where it becomes much more spongy. There's a great increase in the intracellular beams, between the trabecular beams, and you can just see how that could lead to much easier outflow. In addition to outflow, there may be some inflow effects, but there's also been this new sort of novel observation that these drugs affect episcleral venous pressure. And because of how the eye works, every millimeter decrease in episcleral venous pressure leads to approximately a millimeter drop in intraocular pressure. And this has been verified now clinically and in various studies that this class of medications can affect episcleral venous pressure, and that may in part be contributing to its pressure lowering effect. I'm not going to spend a whole lot of time on drug side effects in this talk because of all the different classes, but because we have this new class with Rho kinase, I just wanted to point out a couple things that I see fairly commonly. Number one is this corneal verticillata, where you get deposition of the drug in the cornea. Usually asymptomatic and no effect on vision or comfort, but occasionally it can. And I've seen some patients who get more profound changes in deposition in the cornea where it definitely does bother them, and you have to stop the drug. But you have to look for it and just get this finely lacy buildup of drug in the superficial cornea. You also tend to get these little subconjunctival, petechial, perilimbal hemorrhages. And I see these fairly commonly. It's thought that this is somehow related to what it's doing to the episcleral venous plexus and lowering episcleral venous pressure, though we really don't know. But these are very common to see and seem to be of no particular symptom, other than patients sometimes notice it. And sometimes these get a little bit bigger and cause small, larger subconjunctival hemorrhages. Again, I mentioned the fixed combinations that we have today, and those options continue to expand. We also have a lot of generics. in the US and around the world. And I'm going to talk specifically about generics a little bit more towards the end of the talk. But in the US alone, for just latanoprost, we have at least 8 different generics and increasing. And if you just look at all the classes of medicines that we have and all the different combinations of 1, 2, 3, 4, even up to 5 medicines, since we have 5 different classes, becomes a lot of options. And then if you look at all the various brand names and all the various generic options within each of those classes, the number of options for glaucoma medical therapy quickly gets into the thousands. So it becomes a very complex environment in which to work, and what do we choose for who? In the US, we commonly ask our patients about the color of the cap of their bottles, and that's how we can often tell what they're on, but these aren't consistent, and certainly generics don't always have to follow these. Even the brand name manufacturers follow the cap color design only voluntarily. It's not required. So with all of these options, with these different mechanisms of action, we have drugs that work on the trabecular meshwork, the uveal scleral pathway, aqueous humor inflow, and episcleral venous pressure. So we've got 5 classes that cover these 4 different ways of getting at lowering of intraocular pressure. I think one of the things that I always like to do is, when I think about medical therapy, typically today, if we're going to start medical therapy, we still are going to start with a prostaglandin as our baseline foundational drug, assuming there's no contraindications and the patient tolerates it. The question then becomes, though, since the majority of patients with glaucoma cannot be controlled with one drug, or maybe if they are, they won't be controlled on one drug indefinitely, and we're going to have to add something else. Where do you go next? And I think it's worthwhile to think of drugs by these mechanisms of action. That's why I went through that. Because I think that in most cases, for example, if a patient's on a beta blocker, on timolol, that decreases aqueous humor production and aqueous humor inflow, does it make sense to add another aqueous humor drug to that, or to go to a different mechanism? And I think in general, I think that we get better results and keep patients on fewer medicines if we mix mechanisms of action. So if we're on a uveal scleral drug, maybe we go with an aqueous humor outflow or inflow drug as our next choice. Maybe we want to add that episcleral venous pressure mechanism to the mix on top of it, and look at the mechanisms of action and think about the drugs in that way a bit. Oftentimes we just pick them randomly or by what's available, but I think we can give it a little bit more thought and think, how does the drug that a patient's on work? And if I'm going to add something to it, can I pick something that works slightly different so that they're more likely to be complementary? And here's a case in point. So this is a picture I took with my phone of this patient's medicines who came in to see me. This was the parent of somebody who works here in Indianapolis, and their parent was visiting from overseas, because none of these formulations of medicines do we have available in the US. I forget exactly where they came from, to be honest, but these are the bottles that they pulled out of their pocket. They were seeing me for a consult because the family here in the US, when their parent came over to visit, they were complaining about their eye drops and their vision and didn't think they were doing very well and wanted another opinion. So the first medicine there is brinzolamide. The second medicine is dorzolamide timolol. The third medicine is brimonidine timolol. And the fourth medicine is timolol pilocarpine. And the patient had been instructed to use all of these drops 3 to 4 times a day. So we have 4 different bottles. 3 of those are fixed combinations. One of them is a single agent. And we got multiple dosing regimens. Plus the patient says to me that every week or two, they have to hold their drugs and they don't use their drops for a day or two because their eyes get very irritated and the vision gets very blurry. And if they stay off the drug for a day or two, all the drops, things get better, then they'll start up again. And they've been doing this for quite a while. So then I asked, well, so how are you using these drops? And like I said, they were all to be given 3 to 4 times daily. And they proceeded to tell me, they start off with the brinzolamide drop, put it in. An hour later, they put in a second drop of that. And an hour after that, they put in a third drop of that. So that's their 3 times for that. And the 2 in the middle, they were also using 3 times a day. And so then they would start doing that same thing. So they were doing what they were told, but in a completely wrong way. The timolol pilocarpine was the one they were using 4 times a day. And that would be the last drop that they'd use. And they'd put it in at 5, 6, 7, and 8 o'clock at night, 4 times. In their mind, that was the 4 times a day, but it wasn't spaced properly, of course. Plus, you've got another problem here of all the overlap between these drugs. We've got 7 medications between all these drops that cover just 4 classes. So the brinzolamide overlaps with the dorzolamide. We've got timolol that's in 3 different of these medicines. So this patient is getting way overdosed with timolol, and I was surprised they weren't having more significant cardiac or respiratory side effects, but certainly put them at risk for that. And everything was being done wrong. So, I think there could have been a lot of opportunity here to simplify this regimen. To be on these 4 classes of drugs would probably only require 2 bottles. And could have gotten rid of a lot of potential for side effects, misunderstanding, and ocular tolerability issues. So I got a lot of challenges in medical treatment. We've got all these old medicines, new medicines. Do we use them over or underutilized? There's a whole host of challenges with compliance. There's the availability in different regions of the world. Certainly cost is an issue, compliance, tolerability. This is from the American Academy of Ophthalmology. One of the very simple, straightforward algorithms for treating pressure. Start with prostaglandin monotherapy, and is the pressure good or bad, and go from there. But in reality, it's more like this. It's a lot more complicated. And not only is it medicines, but what about laser? What about surgery? If medications, which one? How many medications do you use before moving on to surgery or laser? When is laser or surgery appropriate as first-line therapy? So, medical therapy is mixed up in all this, of course, but it's a very much more complicated process of working between the patient, you as the physician provider, and the healthcare system, whatever that is that you work within, as to what's available and what the treatment norms and practice patterns are, so that we can really control patients and prevent vision loss. Now, let me quickly switch gears for a minute. I want to talk about something that we probably don't talk about enough, which I know is a problem in the US, and I suspect and I'm pretty confident it's a problem globally, and that's ocular surface disease and glaucoma. What we know is that there's a lot of ocular surface disease among glaucoma patients, whether it's dry eye. Globally, there's also other problems, even trachoma and other factors that affect the general population also affect glaucoma patients. And there's a high prevalence of ocular surface disease among treated glaucoma patients. And using a medication is associated with a significant increase in ocular surface disease symptoms, as is shown here in the glaucoma treatment. If you're on one med, two meds, if you're on two meds or more, nearly 2/3 of patients are going to have some ocular surface complaints. And preservatives in a lot of our drugs do disrupt tear film stability in the ocular surface. They cause morphologic changes that I won't go into detail in both the tear film and the cornea. The higher the preservative concentrations, the worse all this gets, and all of this ultimately then affects patient compliance. Patients who have irritated dry eyes, like the example of the patient I gave you, who was having such tolerability that they would go on a drug holiday every week or two for a day or two, just to let their eyes recover, speaks to some of the issues that we create with our medications. And not only is it associated with these symptoms, but there have been studies that show that ocular side effects accelerate disease progression, probably because patients can't be as adherent to their therapy, and their disease progresses more rapidly. So there's a lot of non-adherence among glaucoma patients to their therapy. And we tend to grossly, as providers and physicians, we tend to grossly overestimate how compliant patients are really being. And if you could really measure it, we'd be surprised at how often they miss their medications, either because we make the regimens too complicated, patients don't understand what they're doing, or because of side effects that drives them towards stopping their therapy or not using it as prescribed or as would be optimal. So, easily 50 to 60% of all glaucoma patients will suffer from some form of ocular surface and dry eye disease, and they experience side effects from therapy more often, and they experience greater disease progression because of that. So that gets into, preservative-free therapies when possible, laser or surgery, or even other approaches. Here's some references for all of that. There's a lot of systems being developed to try to get around some of this without preservatives, and to take some of the burden off patients. This is a punctal plug delivery system, which has drug in it. You put in one of the tear ducts, and it releases drug over a period of time. No preservative, slow release of drug. Here's another approach to this from Ocular Therapeutics with a travoprost-containing plug, and low rates of hyperemia. With Allergan, they have their anterior chamber approach to injecting a pellet of drug. Durista is the product name, into the anterior chamber, which slowly dissolves and releases drugs, so patients don't have to put in a drop, but they're getting constant release and sustained release of medication, and it releases it over several months. And interestingly, one of the things that's been recently noted is that the IOP lowering may be sustained even after all the drug is eluted out of the pellet that is put in the anterior chamber, to last much longer for reasons that are still being investigated. Here is another device with a ring that had drug in it. I don't think we're ever going to see this commercially. The studies kind of stalled. There's contact lens solutions. And most recently, we have the iDose TR from Glaukos. This is a trabecular device that is inserted into the trabecular meshwork that's loaded with drug that releases it slowly over time. So there's a lot of interest in trying to develop new approaches to therapy. I just wanted to show you a little bit about what may be coming in the future, some of which is available now, to get around some of the issues of complex medical therapy, reducing the burden on patients and reducing ocular side effects. And here's from the clinical trials with that iDose TR. It has an effect that's non-inferior to Timol, reducing pressure 6 to 7 millimeters. I mentioned generics before, and I know that globally, generics are, and even in the US now, generics are the vast majority. It's 80% of the medications that patients get. But I think we have to understand what generics are and what they aren't. Because the assumption is often made that they're just the same as everything else. But there are some studies that show that perhaps that's not always the case. Obviously, there's only one true benefit to generics, and that's cost. They tend to be much cheaper than brand medicines, even with insurance. But they do have some disadvantages. There have been some efficacy and safety issues I'll go through. And that happens whether you're switching from a branded product to a generic or from a generic to another generic. We can't always assume that they're always the same. And there's possible reasons to explain all this. And as I mentioned, drug formulations, eye drops, are actually more complicated to design and manufacture than a pill that somebody takes. To get a drug into an eye drop that has the proper consistency and properties and pH and will stay on the eye long enough to release drug that can get through the cornea and be available to the receptors in the eye where it needs to work, is a very complicated process. So how these drugs are formulated and some of the fine minutia of drug design play an important role. In the U.S., these drugs have a less rigorous approval process. They just have to show that they have the same active and inactive ingredients as the innovator drug, but there's some FDA guidance in there, and they're supposed to be identical in strength, dosage, and route of administration, and to be bioequivalent. Again, look the same on paper, but they're never required to be tested against the brand drug. So we just have to take it on faith that on paper, if it looks the same, it should work the same. Does that always happen? Maybe, maybe not. There's another issue as well, and that's in the bottles. Generic bottles are not, there's a lot of effort that companies spend on their bottles. This is just one example of a bottle that's a generic Timolol. And it looks fairly standard, Timolol 0.5%. Only when the patient gets the bottle, there's no hole in the tip of the bottle. In the middle picture there, you see the cap has a little pointy thing in the middle of it. And what the patient has to do when they get their drop is to screw that thing down really tight and push it, and it pushes it makes a little hole in the top of the tip that now the drop can actually be delivered. Problem is, patients sometimes make a little hole, sometimes they make the hole too big, and so the drop size is highly variable. It leads to a very non-standardized drop delivery, whereas a standard drop should be 30, 35 microns. I've had some patients bring in these bottles where you put out drop and it's I mean milliliters. It's just such a large drop because they made a humongous hole in the top of the tip. And so we have these non-standard bottles. Also, the bottles feel different. Some of them are very thin, some of them are very hard to squeeze. So you get generic differences in bottles, which affect how patients perceive their drug and what they're getting. There's actually been some data, there's been some studies. Here's one looking at a Timolol gel forming solution versus a generic, and it showed that the generic in the blue line there on the right didn't lower pressure quite as well as the branded product. This is the generic latanoprost that came out of India. Just one version of it a few years ago, may have changed, but showed that the latanoprost in the blue didn't work quite as well as the branded product. And here's one where a crossover study was done, where again, it showed a generic not being quite as effective as the brand product. So I mentioned these packaging differences. The packaging differences and fill rates of the bottles are also important, and how quickly are patients going to run out of bottles. It's not only a question of getting a big drop out, but if a big drop is being delivered, the bottle is going to run out sooner, so then patients may run out of drugs before they can get more, and therefore have a gap in treatment. So, will your patient do as well on a generic? You know, in most cases, I would say they do, but we can't assume that 100% of the time because there's really lack of data on the generics. It's assessed to know, it's difficult to know what impact those differences may mean. The numerous generic manufacturers mean that even if a patient gets a refill on a medicine, they may get a different manufacturer for a generic, and the bottles and the bottle fill rates may vary. Some of the components could vary within certain degrees of freedom within the guidance. And we have a big issue in the US because we're used to often having samples around, but that's only for brand name products. You never get a sample for a generic. So I often bring these patients back more often because I feel like I need to in order to understand how well therapy is working. And how much money is really saved because of these extra visits, I think, can be argued sometimes. And it's also impacting our ability to develop new drugs, I think, going forward. But this is the world today. So here's a picture of our Eugenia, Maryland Glick Institute, where I have the privilege of working. I've really appreciated everyone's attention. I'd like to now move to the Q&A, if I may. So we have a first question here about the role of prostaglandin analogs in pseudophakic eyes. Good question. So I think that the question stems from concerns about pseudophakic eyes and cystoid macular edema, probably. There is an increased risk of cystoid macular edema, but it's very low. And what I do is in patients who have risk factors for cystoid macular edema, whether that's pseudophakia, also depends on whether or not they've already had a capsulotomy, but they've also got diabetes, if they have some history of uveitis, if they've had previous macular edema before for some reason from a vein occlusion. I will often treat those patients, especially if they're going to undergo cataracts, some sort of surgery with a non-steroidal, but I think you can use them comfortably. And the majority of patients who are on prostaglandins are pseudophakic. But if you do see a change in vision, do take a look at the macula. But they're perfectly safe to use. Just analyze your patient and see if they have other risk factors for macular edema to where you may be adding just one more thing. There's a question about, can we use rho kinase as initial treatment? Yes, you absolutely can. Where I've probably done that most often is in patients who would have a contraindication to a prostaglandin. For example, a patient with uveitis could be considered a reasonable candidate for initial rho kinase treatment. I will often often in those patients start with other drugs, aqueous suppressants and things, but I think a rho kinase inhibitor is not inappropriate in that circumstance. There's a question here about tear film disturbances with in patients with chronic glaucoma therapy. I prescribe. I think what we have to do is, for patients that we're putting on medical therapy, is we want to make sure that their baseline ocular surface is as healthy as possible. So if they have any blepharitis, treat it. If they have pre-existing dry eye, treat it with artificial tears or whatever, so that we're not adding then the burden of the glaucoma medication and preservatives to the situation. So we should be concerned about tear film abnormalities and ocular surface disease, and we should address those up front in our glaucoma patients to make them more likely to be successful with their medical therapy. There's a question not related to this, but what it said the TNT rule in glaucoma. I wonder if that isn't referring to the T-SNIT, which is the relative thickness of the retinal nerve fiber layer around the nerve. So I apologize if I'm looking at that wrong, but that just refers to the relative thickness of the retinal nerve fiber layer as you go around the nerve. So there's an interesting question. So in my opinion, what's the efficacy of prostaglandin analogs compared to SLT as first-line therapy for ocular hypertension and glaucoma? I think that most of the evidence today suggests that out of the gate, in a previously untreated treatment-naive patient, you can get a pretty equivalent initial pressure reduction with SLT or a prostaglandin analog in a patient. Of course, patients vary and so forth. The problem is that laser, by and large, is not a long-term treatment. On average, you get a couple years, let's say. Whereas if someone's effective to a prostaglandin analog, the likelihood is that drug will continue to be effective because the rate of tachyphylaxis or drug resistance is very low, 5%, maybe 10% at worst estimate. Whereas with SLT, 50% of those lasers will not be working within 2 years. So I think it's fine to consider initial SLT treatment, but that doesn't mean you're probably not going to end up on either repeating the laser or going on to add medication at some point, because glaucoma is usually, for most patients, a 20 or 30-year disease. So we have to think of the long term. There's a question about the role of ALT, argon laser trabeculoplasty. Argon laser trabeculoplasty and selective laser trabeculoplasty, SLT, work equally as primary treatments. There's no evidence that shows any difference. The only evidence that shows a difference is with retreatment. There's a much higher rate of success with retreatment with SLT, regardless of whether a patient initially had an SLT or an ALT. Doesn't seem to matter. But the success rate for repeat laser is much higher for the second laser if it's an SLT. There's a question about the PAPs. So that's the periorbitopathy side effects from prostaglandins. Will it be reversible if you stop? And the answer is yes. The periorbitopathy, the eyelid skin darkening, lash growth, all of that absolutely will reverse after stopping a prostaglandin. there's there's the rare patients who may get some iris darkening, and that will probably reverse as well, but it's much slower in my experience, and it's very infrequent as well. And it's usually just in those mid-colored irides that are sort of light tan, who get a little bit of darkening. Yeah, after initiating glaucoma medication, when will you follow up with the IOP, visual field, and OCT? Yeah, sort of a couple different questions in that. So I think anytime you start a medical therapy, you need to give it sufficient time to see if it's effective and how well it's being tolerated, and to make sure the patient understands what they're doing and is administering it correctly. So, that depends a little bit on the medicine, but in general, if you can check their pressure a month or so after starting therapy, that's going to give you some idea of how effective it is, and if the patient's having any problems or side effects from it, and if they understand it and are using it correctly. As far as the visual field and OCT, it depends on their stage of disease. If you're at very early disease, and there's not much going on, you can repeat it several months later, or get a new baseline whenever you want. If it's someone who's got more advanced disease that has progressed recently, and you're adding therapy to try to stop progression, then you should probably repeat the visual field and OCT and look at the nerve more often. So rather than waiting 6 months to do your next field, maybe in 2 or 3 months, you want to repeat a visual field to see, number one, to confirm what you thought was progression, it was really progression before, and number two, to see if it's still getting any worse. There's a question about the cost of rho kinase compared to fixed combinations. Cost issues are so local and so variable around the globe. I think it's hard for me to say, other than, the rho kinase is our newest class of medicine, so they're usually brand name drugs, and are the most expensive drugs in the US right now because of that. So I think you really have to look at your local environment and what the various costs of drugs are in your region or your area. Does using a nanodropper decrease drug efficacy? Great question. In general, the amount of an eye drop that actually gets absorbed is a very small amount. Probably 80% of the drug, if you put a regular 30 microliter drop on your eye, about 80% of it is not going to be absorbed. And the nanodroppers can be very effective in prolonging the medication and even in reducing the side effects by reducing some of the preservatives. So I've never seen any evidence that suggests that these nanodroppers decrease the drug efficacy as long as they get applied properly, and the entire nanodropper drop gets in the eye. With the standard size drops, I usually tell patients, they'll feel like, well, I got some of the drop in my eye, but a lot of it ran out. And I say, if any of it got in your eye, it was more than enough. So I think that if a nanodropper is used and it gets in the eye completely, it should be fine. There's a question about which drug do I prefer to use after trabeculectomy, if any. First of all, after trabeculectomy, I'm hoping I don't need any drug. My goal when I do glaucoma surgery is hopefully to get patients off drugs, and that I think I do patients more benefit by getting them off drugs than anything else with trabeculectomy sometimes. But if the pressure is still such that I need a lower target, or the trabeculectomy is functioning in such a way, I think you can go back to your standard order of drugs. I don't think it really matters. Just like if you were treating, a patient who hadn't had surgery. So and this is assuming the trabeculectomy is well healed and it's sort of a long-term situation. If you're having trouble early on with a trabeculectomy, in the first month or two, and the bleb doesn't look great, then it may mean that that's a trabeculectomy. It's on its way to failure, and may need some intervention to try to needle it or raise it back up, or modify that surgery, cut sutures to try to get better flow by mechanically manipulating the bleb. Where do MIGs stand in the severity of glaucoma and long-term control as an alternative to trab? Yeah, very, very relevant question today. Whole different talk, other than to say that we're in a highly fluid environment when it comes to glaucoma surgery and the role of MIGs and the different MIGs procedures, whether they're device-based MIGs procedures or non-device-based MIGs procedures that don't leave something in the eye. How does the wound healing happen? I think that's undergoing evolution as we speak, and people are at different points in the scale on that. I primarily use MIGs procedures in combination with cataract surgery, myself in patients with more mild to moderate glaucoma. With advanced glaucoma and patients who I'm really concerned could go blind from glaucoma, I'm still going to trabeculectomy. We've got a couple more minutes here. What is the first choice in normal tension glaucoma in a highly myopic eye? I think still the first choice for medical therapy, if that's the question, would be a prostaglandin. I don't think that's an unreasonable start. The key is where do you set your target pressure? And from all the studies and everything we know, number one, you have to understand the diurnal characteristics of what that normal tension glaucoma is doing in a high myopic patient, and that we've got to set a target pressure reduction of at least 30% below baseline, and go from there. When should we consider tube shunt surgeries for glaucoma is another question. For me, I don't do a lot of primary tube shunts unless they're in eyes that are likely going to fail a trabeculectomy. If I feel a patient needs surgery for primary open-angle glaucoma and they have advanced glaucoma, I will usually go to a trabeculectomy myself. In patients with, uveitic glaucoma, neovascular glaucoma, and the like, those I will go to a tube shunt. The other patients are then those who have failed a trabeculectomy. So I'm still fairly standard on this. I've been at it for a while. I feel fairly comfortable with trabeculectomy surgery. But again, this is an area where over time things are starting to evolve and shift. But it basically boils down to how low a pressure do you need? If you're going to be okay with a pressure in the mid to upper teens on 1 or 2 eye drops, a tube shunt's likely going to get you there. Yeah, however, if you need a pressure of 10 on a patient who's had multiple problems with glaucoma therapy, you're not going to get there with a tube shunt. So you have to think about goals. What is your goal for the surgery? And to choose an option that's likely to get you there. There's a question about pregnancy with advanced glaucoma. Which eye drops do you prefer? Unfortunately, none of our drops have proven to be particularly safe, because those studies aren't done. All of our medicines have potential. Beta blockers can be concentrated in breast milk. Alpha-2 agonists like brimonidine can cause hypotension and apnea in a newborn or young children. Prostaglandins are probably pretty safe, but prostaglandins were first discovered in research on uterine contractility, and can be used as an abortifacient in horses and things. So there's, carbonic anhydrase inhibitors early on in early pregnancy can maybe have some limb abnormality risk. So I think you have to use medications with caution in pregnancy and in consultation with the patient and their OB or physician who's helping that patient. Does long-term anti-glaucoma medication make the lens soft and are more difficult cataract surgery later in life? I don't think it makes them more soft, but glaucoma medications probably over time do increase the risk of developing cataract, but not necessarily make the cataract surgery more difficult. I think that this disruption of the aqueous environment can certainly have a response. Unfortunately, we are at our witching hour here for the close of today's webinar. I wish I could stay and answer all the questions, but there were some wonderful questions. I hope this was useful for everybody, and thank you very much for your time and attention today.